So basically, there are stories that we hear every day, every 15 minutes during the day, from our patients. So for those who didn't connect the dots there, patients tell us their stories, and their stories are so consistently frustrating to me, and I think to anybody here who cares, which is everybody, that people suffer with issues that they don't need to be suffering with. And the challenge for us is that there's so many nuances, so many different stories, and so many variations on similar themes that I think I would venture to guess that I think there are a lot of people out there who feel like they're alone in a lot of this stuff.
Mm-hmm.
And the truth is, you're not alone. You know, you're not alone in being frustrated with, unfortunately, I think, you know, you're not alone in being frustrated with a healthcare system that sometimes, really, more often than not, doesn't work well for people who have issues with nose and throat.
Patients want to be believed.
Sure.
Like that is you know, to recognize that what they are feeling is true to what they're feeling, mm-hmm. and that I believe them, or you believe them, or the other providers here believe them. That's powerful, and I think it's meaningful, because a lot of patients come here and they have tried gazillions of things, and maybe have had imaging or whatever it might be, and are like, I'm sorry, you know, they're made to feel like that's not real, or that nothing can be done about it. That's frustrating. It's frustrating for me to hear. It's frustrating for patients, and so it's validation that what they're feeling is true to what they're feeling.
So how many patients do you see that have been seen elsewhere for the same issues? Not necessarily ENT, who've been seen elsewhere.
Oh, gosh. Well over 95%.
Like,
I mean, almost
everybody.
Right, because I mean, these are common problems for normal people out there trying to live their lives that are suffering with issues that can be addressed. Because, and this is the thing that I've learned, you know, coming to Advent and in thinking before, is that, you know, you can either do something or you can't as a surgeon, right? Like, we train to do things to help patients, and so we can either say, hey, we're willing to try something, you know, that can make a meaningful impact in your life, mm-hmm. looking at all options. You don't have to do anything, right? I mean, we deal in the quality of life for the most part, unless we're treating severe sleep apnea, and obviously it has long-term consequences, but it's taking, rather than a hands-off approach and saying, I'm sorry, there's nothing else I can do, you just have to live with this, or,
right.
Hey, these are the things that we can do, these are the options. It can get real invasive, but it could also get real less invasive, you know?
Right.
And being able to,
although even it's stopping at the very first thing. So not everybody that we see has been seen elsewhere. Almost, you know, meaning they've gone to the primary care doc, they've gone to urgent care, they've gone here, they've gone there. Many folks have gone to see an ENT, and how many of those patients that are suffering, that have gone and said, oh, there's nothing to do, or maybe they've had stuff done that just hasn't been effective, but most often than not, they just never had anything done.
Right.
You know, then the next question or reality is, how often is there something that can be done that's actually going to help them?
You mean that's potentially still, we can do something to help them?
Yeah, that person who's been dismissed everywhere else, they come in, first thing is just listening to what they've got going on.
Validating that their experience is real.
But then how likely is that patient actually right, that this isn't right, this isn't the way it's supposed to be.
I know.
They've been told this is hey, this is it, buddy, this is your life. You know, here's the Flonase, have a good life, kind of a thing.
Yeah.
And you know, they should be pissed off.
Right.
Like,
I agree.
And it's unacceptable. It's dismissive. It's the opposite of any possible reason I got into medicine to begin with.
Right.
Is the norm everywhere else. And for the life of me, I've never figured out where that's coming from, other than it has to be, I think, out of ignorance. Ignorance, not on the part of our patients, because they're generally right. Ignorance on the part of other providers that either don't care or can't do anything, or both of those things, but they just haven't figured it out.
I think it's ignorance and it's fear. I mean, you know, again, you know, and this goes for any doctor, to be honest with you out there, and maybe this is getting too deep into physicians, but surgeons especially, but even other docs, will direct you towards things they feel comfortable doing.
Sure.
There's always a bias to push patients towards, hey, there might be 5 other ways of doing this procedure that are better, but like I didn't train that way and I don't feel as comfortable because I'm not as experienced. So I'm going to go ahead and kind of like pitch you kind of this way of doing something to treat your knee problem, or who knows. I mean, it could be a gazillion things. And you can take that and make that analogy for the nose, and there are some ENTs that feel very comfortable doing sinus surgery, and there are some ENTs who don't feel very comfortable doing sinus surgery.
Right.
But like as a patient out there in this world, you're never going to be able to get through those filters for the most part, unless you have some sort of background knowledge of who is the person that you should see to do X or Y. And so that's kind of a long thing, but like, patients coming in that have been told there's nothing to do, I would say out of all of those patients, maybe 90, 95% of patients, you can do something and still improve upon what they told. Sorry.
So the patient that's coming in frustrated with their nose, say that's their complaint. Their nose is stuffy. They've got recurrent sinus infections. Those issues. If somebody's got a nose or sinus issue, it's one of 2 issues. Mm-hmm. What are those issues?
It's either anatomy or it's lining.
Period. End of story, end of sentence, nothing more. So for somebody who's frustrated with their nose, it's anatomy or it's lining. And anatomy issues cannot be treated with medications.
Correct.
Correct?
Correct.
Lining issues might be. Most folks coming in to see us, they've tried this, that, and the other thing that haven't really helped them. Most folks who are suffering with nose issues and sinus issues, it's actually a combination of both of those things, anatomy or lining.
Right.
So when somebody comes in to see us, our goal and role is to get an understanding about their situation, understanding about their anatomy and lining, and then talk through the different options to come after that. And for whatever reason, that simple concept of the anatomy and lining issues it didn't get taught in med school, apparently. Didn't get taught in ENT residency, apparently, because a lot of folks are walking around with anatomy that's compromised, that there are simple things that can be done to help it, that never hear about those simple things.
And who else is going to make an impact on anatomy if it's not an ENT surgeon?
Right. Yeah. It's
otherwise we are no different than an allergist or a primary care or family practice or OB who's treating the nose or whatever it is. Because then then we basically just truncated like what we can do, and we're no different than anybody else.
Right. So if somebody's going to have surgery on the inside of their nose, the person doing that surgery is an ENT.
Right.
Like it has to be an ENT, which means it has to be us. That's our specialty.
But if we're not willing to do anything and we want to tell patients, I'm sorry, there's nothing else we can do because we don't want to address the anatomy, then where does that leave that patient?
Which gets back to the fundamental frustration that's my frustration, that's our patients' frustrations is, why doesn't everybody want to, help folks? And I think, unfortunately, that the way that things, I don't know. I don't have the answer. I don't have the answer, and I think the answer that I can deliver is that it's not the way it's supposed to be. It shouldn't be that frustrating to get good care.
Well, and I think, again, it leads into what do you feel comfortable doing? Because, because we are in a place, we talked about this, that's independent, we can decide that we want to do things in office, we can offer things that other systems can't offer. We are lowering risk to do things in an office setting for patients that again can have a great impact in their lives at a less invasive cost, essentially, to start doing something for somebody.
Sure.
Right? Versus taking them in the operating room. It's a big deal for patients. And as a surgeon who's been on the other side of the who's been a patient myself and had surgery done, it's scary. And so in patients don't want to take a leap to go to the operating room because you're put to sleep and you have downtime, and it's just this whole other thing. And surgeons, that's not taken lightly, and it shouldn't be. And so surgeons may not feel like, hey, to try and just move the ball maybe a little bit down the field, or what they might believe is moving the nose down the field a little bit, that might not be a worthwhile risk to them, which is why they maybe take a hands-off approach. Whereas if we say, hey, look, let's try something in the office, it can have a big impact. Worst case scenario is it doesn't get you as far as you want to go. We can still do other things as options, but that's a worst case scenario.
Yeah.
It just, again, it's just, it comes down to what one feels comfortable doing. And I think that, as surgeons, we have to be willing to say, yes, I'm willing to try something because a patient's suffering and they come in, and who else is going to help them then if we don't step up?
Yeah. Well, and even that fundamental So if you've got a nose issue, if you've got a sinus issue, you've either got an anatomy issue or a lining issue, period. If you have both of those issues, if you don't address the anatomy issue, you can use all the medications in the world and it's not going to help the lining. And how the rest of the world operates is flip opposite of sanity and reason, is that they will try to spray and pill you, try to hit the lining with medications when the anatomy is shut down.
Right.
And so flip that around. If somebody's got an anatomy issue and a lining issue, and we can get the anatomy open, especially if we can do that in a low-key manner, let's do that, and let's see how the lining likes that. And the lining generally likes it when the nose is open and those sinus passageways are open. Right. And so for most of our patients, our goal when we see somebody is to get them better. And better to me means if we can do something that's going to fundamentally get them on the right pathway to minimize the use of medications, including antibiotics and other things, that's the path that we would want them on. And part of that's because that's the path I would want. If I have a choice between, sort of putting Band-Aid after Band-Aid on a situation that I know could be resolved, without a Band-Aid, with something that's actually going to get to the root of the issue, get to the root of the issue. And if I need a Band-Aid on the back end of that, fine. But don't sit and tell me that here's a Band-Aid, here's a Band-Aid, here's a Band-Aid. Don't tell me that that's an appropriate approach, because it's not.
And it's not without cost, literally cost to buy all those medications. What does it do to a person who's taking, think about how many patients we have that come in that have their combination of pill, whatever it might be, that they take daily, maybe throughout the year or just during allergy season, that's their Claritin D and whatever else it might be, right? Like,
sure.
I don't know what impact that has on the body systemically. And, we're in a day and age where we don't want to load our bodies up with medications unnecessarily. And I get why they're doing it. We get why they're doing it because either someone's told them that's what they should do, or they're grasping at straws to try and figure out how am I going to get a little better in my nose so I can kind of manage.
Sure.
So I get it. But, I feel like it's a win for us if we can get their nose working without having to have any of those medications. And oftentimes they don't need them anymore. You get them breathing better, and then they can stop buying all that stuff.
Is there somebody you think? Let me ask you a simple question. If how many medications do you want to take?
0.
That's my answer too. Are there people walking around on this planet that want to be taking 1, 2, 10, or 50 medications?
I can't imagine.
Because that's how the healthcare system is set up right now. And so for us, I'd say what's our bias? Everybody's bias. Everything's got an angle. Our angle is from a nose standpoint is if it's blocked, let's get it open. If it's open and we need to use medications, let's use medications. But let's not throw medications at an issue that needs.
Stack them,
right. But who would want that? I don't want that. I don't want to take anything I don't have to take. Period. End of sentence. There's not another sentence. If I can avoid it, let me do that. Right. Now, if I don't have an issue, then leave me alone. If I have an issue, so say your issue is that your nose doesn't work, your nose is blocked up, and you are maybe we're insane here, but you are of the same mindset as us, is, boy, yeah, my nose is blocked up. What do you want? You want to breathe better. Okay, you want to breathe better. Which you're not you're asking for a solution of, I want to breathe better. You're not asking for, all the things I can throw at you medication-wise to, how do you say this, to sort of help a little bit, you know what I mean? We can stack them, I can give you this, that, and the other thing, and it's still never going to get you as good as you could be if you could just breathe properly, right. But that's what we're going to do for you.
And think about how many of those patients have not had scans, right? We talk about, why do we get scans, and why do we have scanners in our office so that we can, be able to get that on a patient to answer questions about what's going on with this blueprint here.
So to answer that, for those, a scan is what? X-ray images.
Correct.
The only way to figure out if somebody's got an anatomy issue in the sinuses and some parts of the nose is with
a CT scan of the face, right? Imaging.
Imaging.
Yes.
Is there another way that you know of? There's no other way.
Correct.
So if you are going to have a nose procedure done, and you've never had imaging done, how do you know that there's not something going on outside of the nose?
I don't.
The sinuses.
I don't.
So if your nose was at stake, say you were getting set up to have, say you've got a deviated septum, which you might in fact have.
Which I do, and I want to touch on that in a second, but go ahead. Yes.
Yeah, so say you've got a deviated septum, someone looks in your nose. To find out if somebody's septum's deviated, we just need to look in your nose.
Correct.
To correct a deviated septum, we need to take you to surgery. Not a big deal, we can do that. If you had a deviated septum, because you have a deviated septum, does it mean that you don't have issues elsewhere in the nose and the sinuses?
No.
And if you had issues elsewhere, if you had the choice, would you like to have those issues addressed at the same time you had your septum fixed or at a different time?
At the same time.
Would you want the information before surgery or after surgery?
Definitely before surgery.
Are you insane or are you sane?
I'm saying.
Are you like every single other person walking around this planet, I think, but that's not the way it's normally done.
Right,
correct?
and so how many patients have you seen, whether they've been operated on before or not, and you say, hey, have you gotten a CT scan of your face and sinuses? How many of them say, yeah?
No, I mean, it's crazy to me. It's crazy to me how what the sort of the standard is out there. Now we have the benefit of office-based imaging. Why do we have office-based imaging?
Because it allows us to get patients access to understand that blueprint. I mean,
And us,
yeah.
right? Like I'm not a magician. I don't think you're a magician. I can't see into areas I can't see without imaging. With our office-based imaging, so every Advent office has a CT scanner, low dose, meaning like low radiation dose, which is what we want.
Right.
Images are immaculate, which is what we want. We need to be able to see. If you can't see, you can't know. If you can see, you can know. Once you know, then we can have a conversation about what we choose to do or not to do about that information.
Right, but that's also why we have a scan. Look, it's not like a patient can't go somewhere else to a hospital and get a CT scan, but what's essential as part of our visit with the patient is you can get a scan here, we can review your scan immediately.
Right.
Right, you're not having to schedule a follow-up appointment for that and run around the world trying to figure out where you can get in and then wait at some other office or hospital system. So it's a matter of get that scan, communicate with your surgeon, walk through that scan together, understand what that blueprint is, and then come up with an attack plan essentially.
Is there somebody that if there was somebody that who is getting set up for surgery on, let's go back to the septum again, that didn't have imaging, would you make sure they got imaging before they did that?
100%.
Yeah.
100%.
And there is no counter argument against it other than I don't want the information. I guess the only counter argument I can think of is I don't want the information because we're good here.
Well, it's because we've seen too many times on the back end of somebody having septum done and still having nasal congestion. Their complaints are no different. Maybe they get better for a month or two, and then they get back to their baseline because, and this was what I wanted to touch back up on, every patient has a deviated septum. This is the secret of ENT, right? So what's communicated out there in the world, what a primary care looks in your nose and patients have in their heads, for good reason, because it's communicated this all the time, is that you have a deviated septum. But I've never seen a perfectly straight septum, ever, in my lifetime, okay? And so the reality is, how bad is that deviation, where is that deviation, that's what matters. And so if you assume, rightfully so, that every septum is deviated, likely it isn't the problem a lot of the times.
So to recap there, if you come in with a complaint that you can't breathe through your nose, and we look in and we see you have a deviated septum, does that mean the deviated septum is the cause of your problem?
Definitely not.
It could be.
It could be.
It may not be.
Correct.
So, but the typical practice is you can't breathe through your nose. We see your septum is deviated. Let's fix your deviated septum, which might work, might not work. Our approach is you can't breathe through your nose. We see that you have a deviated septum. That might be the tip of the iceberg. There may be other things that are there, and oftentimes, much more often than not, I'd say, well, much more often than not, if somebody has deviated septum, there are oftentimes things we can do in the office that are much less intense than straightening the septum.
Right.
And achieve that same goal. If the goal is to breathe well through your nose, then we want you to do that. And if somebody needs their septum straightened, we can certainly do that. But if it's a matter of you want to breathe through your nose, we'd rather sort of not go through a big surgery if you don't have to, we can do that.
Right, and I tell patients all the time, I like doing septum surgery. I do a lot less of it now.
Sure.
Because I just don't need to address the goals they have, which might be nasal congestion or breathing, and that's a lot of what we deal with. And so, hey, if I need to address the septum, I'll do it, not a problem. But like the reality is I do a lot less because I don't need to do as many more because that's not necessarily how we get the win for patients.
Right. Yeah, it's the end goal in mind, which is okay. That if somebody's got a breathing issue, let's get that get that better, and let's do that in the lowest key, yet most active and proactive manner possible. And that oftentimes is, and it's not by and for us, and our approach is, let's not bury anything. Let's bring everything to the surface. Let's get all the information out there in front of us, and then let's make an informed decision. We are the guide, so we're going to help you understand what this information means. And then, again, if somebody's got issues with their nose or sinuses, there's often many different options there, running the gamut from doing nothing, maybe medications. That's usually not kind of a big go-to option for most of our patients.
Because most of them have already been through all that.
And most of them have anatomy issues that aren't addressed. And so, yes, can we prescribe antibiotics? Yeah, we can do that. Can we hand you a Flonase? We can do that. And there are times where it's appropriate, but it's not appropriate if the anatomy is shut down. And so let's keep that in sequence. Let's understand. We got to be able to see to understand. Once we understand, we got to be able to do. We can do with the best. And if we can do, let's do in the manner that's most aligned with how somebody wants to be taken care of. And it's really the nice thing for us is how our approach has been structured is it is for the sane, it is for the average, it's for me, it's for you, it's for everybody out there, because we're doing things and we're approaching it in the manner that I want to approach, you want to approach, you want your kids, I would want this approach for everybody and anybody, which is why it's for everybody.
And it's not rocket science.
It's not, but it's even the rocket scientists can't do their rocket scienting very well if they can't breathe well. True? So if you want to build the best rocket, breathe through your nose.
You better sleep well.
Sleep well. I hope you're sleeping well. If I'm on your rocket ship, I hope you're sleeping well and breathing well.
Or if you're a pilot.
Yeah.
Or a truck driver. Okay, all of these things, right?
If you are a human being walking around on this earth, if you can't breathe properly, it's going to impact you. Whether you're a rocket scientist or a neurosurgeon, I don't care what you do, you're not going to do it well if you can't breathe well.